Earlier, we delved into trauma team training. Now transitioning to discussing airway management alongside our ABC primary survey, encompassing airway, breathing, circulation, disability, and exposure. Today, our focus shifts to exploring the intricacies of the breathing component. In the scenario of a trauma patient with a clear airway but unable to breathe, intervention becomes necessary, requiring the caregiver to provide assisted ventilation for the patient. Effectively assist a trauma patient who may have a patent airway but is unable to breathe independently. It's essential to have an ambu bag and a mask on hand to facilitate ventilation and provide necessary support, ensuring timely intervention and patient care. To assess breathing, follow the standard approach. Inspect, auscultate, and participate. During inspection, look for normal breathing patterns, including symmetrical chest expansion with each breath. In trauma patients, asymmetrical chest expansion suggests respiratory issues requiring attention. If you notice a decreased or increased respiration rate, or if there's a penetrating injury from the chest up to the neck, inspect for signs such as flailed chest or sucking chest wounds. Additionally, observe for the use of neck or respiratory muscles to breathe. During palpation of the patient, while assessing chest expansion and movement, it's crucial to check for any shift in the trachea, which typically moves away from the site of pathology. Check for tenderness in the ribs or sternum, and also examine for any crepitus, as these indicators can provide insight into the patient's breathing and the condition of the surrounding tissues, especially around the ribs and neck. When you percuss, you're assessing the tone of the chest. A higher tone may indicate pneumothorax, while a dull note suggests hemothorax, possibly caused by the accumulation of blood in the chest cavity. Another crucial step is auscultating the chest. Utilize your stethoscope to listen for normal, reduced, or absent breath sounds. In cases of moderate pneumothorax, you may hear crackles or a sucking sound, indicating air trapped in the chest cavity. The signs of pneumothorax are rapid shallow breathing, as the affected lung cannot expand fully due to the accumulation of air outside the lung, pneumothorax. The patient compensates by breathing rapidly and with shallow breaths to maintain oxygenation. Ipsilateral decreased breath sounds. The side of the chest where the pneumothorax occurs will have diminished or absent breath sounds because air in the pleural space prevents the lung from fully expanding and exchanging air. Ipsilateral tympany, high note, to percussion. When percussing, tapping, the chest on the affected side, a high-pitched, drum-like sound, tympany, is heard due to the presence of air in the pleural space, which resonates differently compared to the normal lung tissue. Shift of trachea to opposite side. The accumulating air pushes the mediastinal structures, including the trachea, away from the affected side, causing a visible deviation of the trachea toward the unaffected side. Hypotension. Tension pneumothorax can lead to decreased venous return to the heart due to increased intrathoracic pressure, compromising cardiac output and leading to hypotension. Jugular venous distension. Due to decreased venous return to the heart, jugular venous distension occurs, where the jugular veins in the neck become visibly engorged, indicating impaired venous drainage. These signs collectively indicate a medical emergency requiring immediate intervention to decompress the trapped air and relieve pressure on the affected lung and mediastinal structures. If faced with a pneumothorax situation away from medical facilities, promptly insert a 14-gauge needle into the second intercostal space anteriorly. This intervention allows for immediate relief, enabling the patient to breathe while awaiting chest tube insertion upon hospital arrival. If the hospital is distant and patient transfer is necessary after the needle insertion, consider securing a glove above the needle, a technique known as glove and needle, to facilitate safe transportation until the patient receives further medical care. The definitive treatment for pneumothorax and hemothorax is the insertion of a chest tube. After initial first aid at the site of injury, the patient should be transferred to a hospital equipped to perform chest tube insertion. Apart from trauma cases, healthcare providers may encounter patients who have drowned in bodies of water like rivers or swimming pools. Adapting to such patients involves addressing the risks of suffocation and aspiration of water or other substances into the lungs, which are often the leading causes of death in these cases. The initial steps involve administering first aid by rescuing the victim from the water and placing them in the recovery position, ensuring the head is lower than the legs to facilitate drainage of fluid from the mouth and lungs. Artificial ventilation or aspiration is then administered if the patient has a pulse but is not breathing. Prompt transport to the hospital follows to continue medical assistance. The basic breathing treatment includes placing the patient in the recovery position, ensuring warmth, evaluating airway, breathing, and circulation, observing for changes, administering fluids, and assessing for additional injuries. This comprehensive survey facilitates better treatment and patient evaluation. If the patient is unable to breathe, advanced treatment is necessary, including intubation to assist ventilation and the insertion of a chest tube while awaiting further intervention.